My name is Ian Flynn, and I'm the Director of Hematologic Malignancies Research at the Sarah Cannon Research Institute in Tennessee Oncology here in Nashville, Tennessee. The lymphomas are a group of malignancies that begin in the lymph gland. Usually we think about the lymph gland when we have a cold, and we can sometimes get swelling of our nodes in our neck. That's most people's awareness of the lymph tissue. In fact, we have lymph tissue throughout our body, pretty much everywhere in the body except our central nervous system. When someone gets a cancer of the lymph tissue, that's called a lymphoma. In the same way, if someone gets a cancer of the lung, that's called lung cancer. When people get a malignancy in the lymph gland, it's called a lymphoma. This is different than when someone has a malignancy that begins in the lung or colon and breaks off and goes to the lymph glands. That's a metastatic colon cancer or metastatic breast cancer. It's not lymphoma. Lymphomas are diseases that arise and begin in the lymph gland. There's probably 30 or 40 different types of non-Hodgkin's lymphoma, depending on what classification scheme we use. But they can roughly be lumped into two families of disorders. Those disorders that are slow-growing, that we think of as indolent lymphomas, and disorders that are more aggressive, grow quickly, that are a separate family of diseases. There are a lot of exceptions to these rules, but in general, that's a pretty good rule of thumb. The indolent lymphomas, as you might guess from the name, grow very slowly. Sometimes people have these diseases for years before they're diagnosed. Frequently, a patient will notice there's a node in the neck that pops up, or underneath the arm, or perhaps in the groin, and they go seek medical attention about that. The aggressive lymphomas, on the other hand, again, as the name may suggest, grow very quickly, and the symptoms change sometimes overnight. Patients with aggressive lymphomas often complain of what are called B symptoms, which is weight loss, 10% of body weight over 6 months, night sweats, drenching night sweats, to the point that people have to change their sheets in the middle of the night, or their pajamas, or fevers. So people can have fevers as well. These are B symptoms and typical symptoms of aggressive lymphoma. Now, the low-grade lymphomas, because they grow very slowly, we don't need to intervene very quickly. Many patients, when they originally come in to see the doctor, and after being diagnosed with after a biopsy proves that they have a low-grade lymphoma, we often sit and do nothing. We sit and watch and wait. And this is usually an initial glance for patients, very disturbing. Everything we know about cancer treatment and learn from public service announcements is that the quick diagnosis and treatment of cancer is the key to success. This may be the one exception to the rule, or one of the few exceptions to this rule, whereas patients with low-grade lymphoma, we know that from several decades of clinical trials, that early intervention does not improve survival. That doesn't mean intervention doesn't improve in survival. It just means that treating when someone does not have symptoms, that they are not helped. So some of the things that we look for after people are diagnosed with low-grade lymphoma is how extensive is the disease. Do they have large lymph nodes inside by CT scans? Are the lymph nodes growing and it's about to press on a vital organ? Or does the patient have pain or other symptoms from the lymphoma? If the answer to one of those questions is yes, then we'll usually begin a therapy at that point. This is radically different, I think, from patients who have aggressive lymphoma. Probably the typical example of an aggressive lymphoma is someone with a diffuse large cell lymphoma. If a patient with a diffuse large cell lymphoma, we usually like to begin therapy very quickly. In this case, we do know that treating quickly improves survival tremendously. On the large cell lymphoma front, on the aggressive lymphoma front, there's been a lot of progress over the last decade. We know that the improvement in survival is improved by approximately 15%. That's not a relative 15%, that's an absolute. Overall survival has gone from somewhere in the mid 40% to 55 or 60% of all patients with this diagnosis, which, if you think about it, is a huge increase in survival and very hopeful. Low-grade lymphoma, we've also made progress in the treatment of low-grade lymphoma as well. It's harder to measure but in the last decade or so, we've seen advancement in survival for patients with low-grade lymphoma. I think one of the other bit of good news is that is for patients, particularly with low-grade lymphoma, that the therapies are becoming much more targeted and perhaps less difficult for patients to take. And so for many patients, while these diseases, while the low-grade lymphomas are sometimes incurable, but for many patients incurable, they're becoming more, many patients are surviving much longer. And the models are coming closer to what we think of a chronic disease. For instance, for someone who has high blood pressure, while we can't cure them of high blood pressure, we can often treat high blood pressure for decades. For some patients with low-grade lymphoma, that's also true. So the horizon is getting better for both patient populations. So unfortunately, the incidence of lymphoma is on the rise, but in comparison to many other types of malignancies, it's still small. There's approximately 60 to 70,000 new patients diagnosed with a non-Hodgkin's lymphoma in the United States every year. And while that is a large number, and unfortunately it's growing, it is small in comparison to the number of patients diagnosed with prostate cancer or lung cancer. Survival is getting better for all patients with lymphoma, and many patients are living with this disease, and so the prevalence of the disease is also increasing. Many patients ask, why did they get lymphoma? And the answer is usually, we don't know. We do know that certain types of lymphoma, such as low-grade lymphoma, are more common in the West than they are in Asia and elsewhere, where low-grade lymphoma is a very rare disease. There are certain epidemiological patterns that we note in the United States where lymphoma is more prevalent. They're often more prevalent in some of the Midwestern states and close to agriculture areas. Why that is, I think, remains to be determined. The other question we're often asked is, do my family members have to worry about anything? Are they going to get lymphoma as well? And the answer to that is also probably not that clear. There is an increased risk for family members to get a lymphoma. When you think about the absolute magnitude of the risk, it's really quite small comparison to getting other cancers. And whether that's because they inherit some same genetic susceptibility, or whether they were exposed to the same water as a child or some other substance in their environment that led to the lymphoma, we don't know either. Therapy for patients with an aggressive large cell lymphoma is fairly straightforward. It's usually the combination of rituximab and CHOP chemotherapy, or R-CHOP chemotherapy. This is given in 3 to 6 cycles for the vast majority of patients. 3 cycles maybe for patients who have a localized lymph node in their neck or in their arm, or localized disease. And when it's given in a reduced number of cycles, it's usually combined with radiation therapy. Unfortunately, most people have more advanced stage disease, and they're treated with 6 cycles of R-CHOP chemotherapy. This chemotherapy is given every 21 days, and so it usually takes about 4 months to receive this treatment. It's generally given all as an outpatient treatment. Treatment for low-grade lymphoma is a little bit less defined. There are many different options for patients from low-grade lymphoma. They include single-agent drugs such as rituximab, which is an antibody, not a chemotherapy, to combination chemotherapy involving rituximab. Many patients will go on to have maintenance therapy with low-grade lymphoma. They'll receive the antibody rituximab for 1, 2, maybe even 3 or 4 years after they've finished their treatment. This approach has been proven to keep people into remission longer and improve overall survival. There are a lot of new therapies that are being developed for patients with lymphoma, and these are really very exciting and very different from our treatments of the past, which were general cytotoxic chemotherapy that were unfortunately, fortunately are effective, but unfortunately indiscriminate in their side effects and damage normal tissues as well as curing the patient of lymphoma. In low-grade lymphoma, some of these therapies are coming forward more quickly, and they are often oral therapies, not necessarily intravenous. They're very targeted, so they're very selective for the lymphoma in comparison to other treatments. There are a variety of new therapies that are being developed for patients with lymphoma. I'm most excited about a family of molecules that work downstream of something called the B-cell receptor. Such targets include SYK inhibition, mTOR inhibition, PI3 kinase inhibition, and BTK inhibition. And there are a whole bunch of different drugs that are being developed for each of these targets. And sometimes one drug is targeting more than one of these molecules at the same time. As a class, they are very well tolerated. They're almost always oral drugs that do not have the same side effect profile that we think of classical chemotherapy agents. So in general, people don't have all the nausea, vomiting, hair loss, suppression of their immune system that sometimes associates classical chemotherapy. One of the important messages that I like to get across is that you should ask your doctor about participation in a clinical trial early in the course of your disease. I always believe that the best therapy is often delivered as part of a clinical trial. And so clinical trials aren't just for patients who've had multiple prior therapies. They are often for patients who've had no prior therapy. And so please ask your doctor about this. Hodgkin's disease is another group of lymphomas distinct from the non-Hodgkin's lymphoma with a very different biology. The good news about Hodgkin's disease is that most patients can be cured of their Hodgkin's disease with either chemotherapy alone or in combination with radiation therapy. And this holds true for the vast majority of patients with Hodgkin's disease. For patients who relapse with Hodgkin's disease, the standard therapy is generally chemotherapy again with a bone marrow transplant. There's good news on the horizon for patients that either can't go through a bone marrow transplant or unfortunately relapse after that. There's a new very targeted monoclonal antibody known as Adcetris or brentuximab, which is an antibody that targets a chemotherapy agent directly to Hodgkin's disease. And clinical trials have shown that this is a very effective agent for patients with relapsed or refractory Hodgkin's disease and is now just commercially available to your local doctor. If you are diagnosed with lymphoma, there are many resources available to you. I would particularly like to point out the website minipearl.org, as well as other websites such as the Leukemia and Lymphoma Society's website, for which there's a vast wealth of resources to direct you to get the care that you need. I'd also like everyone to think about participating in a clinical trial early in the course of your disease, because this is the only way we're going to make progress and move towards an increased cure rate for everyone.